Welcome to Brain Friends, where two neuro nerds talk all things aphasia, language recovery, culture, and community. I am Dr. Dictrina Celeste Gatson, a clinical speech-language pathologist and neuroscientist.
And I am Angie Cawthorn, stroke survivor and aphasia advocate.
Welcome to our show.
Welcome to Brain Friends.
We want to thank all of our listeners for downloading the podcast. We appreciate everyone listening, so please tell a friend to tell a friend that we are here.
And we are.
All right, we are back, and today we're talking about mental health. Hey, Angie.
Hey, Dr. Celeste, what is going on?
How are you?
I am blessed and highly favored, very excited. We have our first guest today.
I know. I'm so excited about our first guest. I am going to let her tell you about all of her credentials, but this is Dr. Lauren Simone Harper. We both got our PhDs at the University of Georgia. Go Dogs.
Go Dogs. Go Dogs.
Yeah. And so I found that it was so important for this episode to bring in someone that knows this stuff, someone who this is her area. And so I'm going to let her introduce herself and then we'll get started. Dr. Lauren.
Yay. Thank you all so much for having me. I'm so excited to meet y'all. Yeah, I'm Lauren, or Dr. Lauren is cool. Actually, my Instagram is Dr. Lowe, so people call me Dr. Lowe as well. But I'm a counseling psychologist by training. I'm a licensed psychologist in the state of Oregon, but I'm from Georgia originally, as Celeste said. So we got to meet each other at the University of Georgia. The privilege there of getting to meet each other in that time frame. Gotcha. Yeah. And so licensed psychologist by training, I work in the state of Oregon as a psychologist. I actually work in health psychology. So my degree is in counseling psychology, but I had a focus on health. I also have a master's in rehabilitation counseling. So my focus is then on chronic illness and disease management and the mental health aspects of that. So working in integrated care or in primary care, if you will, like if you go see your primary care doctor and you're interested in seeing a therapist or a psychologist, I would be that person to be there to work with you. And my work has changed a little bit in the last 6 or 8 months or so. So I've actually moved out of direct patient care of working with patients and working with a care team on managing kind of a chronic illness or a disability. And now I actually work with our employees at the organization I work for on their mental health and wellness. So I help design programming that are wellness focused or mental health related focus. And we kind of diminish that or present that to different employees. I also can help with critical incidents, like if we have a death of an employee that's spontaneous or something we haven't planned for, we can help support them with that as well.
Oh, wow, that's a lot.
I know.
That's a lot.
That's not all the things even that I do, honestly, but that's the highlight.
Right,
That's the most important part.
Highlights. Oh my goodness. Well, welcome to the show. We have so much so many questions and so many things. Dr. Celeste, it's all about you though. I'm playing my position at the back.
No, it's all about us, which is why I wanted to get started with the icebreaker.
Yes.
All right, Angie. So we're going to let you go first. What activity helps you relieve stress?
Oh, that's what you're going to do. That's what we're doing. That's how we're going to start it. We're just going to drop Edge. Okay. For me,
or should we let our guest go first? You want to let our guest go first?
She's looking like they can't see what she looked like. She's like, don't you do that to me. I got you, Dr. Lauren.
I was just interested in hearing how the hostess describe it first so I can follow suit.
I like the spin. I like the spin. I like it. No, I like where you're going with that. My biggest stress reliever is playing Xbox. I play either Madden or NBA 2K. All right. 44 East, get at me. Y'all don't want to smoke. But no, they don't want to smoke. Okay. And it helps me relax. That's my stress, and baking. That's my two stress relievers. So I try to play the game more because like baking is not that great. You might just want to sit down and play the game real quick. Stop playing with me. So that's my stress reliever. What do you guys got?
I love it. I'm happy to go. I actually wrote down a few things. I'd say my biggest stress reliever, which is newer for me, but actually finding relief of stress in connecting with my friends and just having conversations, whether that's vent sessions, whether that's just catching up. And I say that's new for me because I don't know, like I always enjoy spending time with my friends, but I don't know if I'd always felt as comfortable fully sharing all the things that I'm experiencing because all those things are hard, right? And so you may have a few friends here and there you can really get down to the nitty gritty with, but I have found that there is something to say about in all of my close relationships, I should be able to have a level of divulging something. And when I can do that, that makes me feel closer to them. And that helps me feel like, okay, I've gotten rid of a little bit of my daily stress. I also really love to get massages when I can. That's been my, ever since I work a big girl job and make better money, I can afford that.
Come on, coins.
I like that. And I actually love, I shouldn't say love, but I have found stress relief and some joy actually in exercising, which has been something I've re-engaged with the dancing, which I love.
That's mine. I was going to say dancing.
Oh, I'm sorry. Well, that leads in for you. That's going to be... That's gonna lead
Miss Cheerleader over here. I had a scholarship to dance.
Okay, exactly. Yes, right. So I love that too.
Yeah, so that's my stress reliever is dancing. Y'all, I will have a whole party, like a whole party just from dancing.
Me too.
Lauren, you remember back in the PhD days, which is that's a whole nother episode about having to sometimes go outside of your department or your regular community to find that community that you need. And so we would have dance parties and all the things.
Dope.
And vent sessions and reality TV binge time.
Hair sessions. Lauren taught me how to manage my natural hair.
Oh.
That's therapy.
Okay, so you giving mental health and hair tips. Yes.
Listen,
where have you been, queen?
Listen, we all know our first hairdressers were probably your therapists, right? Or something similar to that.
No, for sure.
Yeah.
Right. No, for sure. They know they know all the dirt, all the good, all the bad. They do.
And they know how to comfort you in multiple ways.
Multiple ways.
Yep. Yeah, we had some fun times. We sure did.
So true. So I thought it was so important for us to talk about mental health. And like I mentioned earlier, you know, oftentimes what has happened is when an individual experiences a stroke or has aphasia and they're going through some of these mental health challenges, I've seen practitioners just kind of, you know, you ask the patient to do something or the survivor to do something and they go into a middle of a breakdown and the practitioner is like, okay, well, can you say these words? Like just totally dismissing what's going on. And so I found it to be very necessary to kind of like iron this out and talk about things that practitioners can do, but then also mental health. And so I looked at some of the literature and it said, you know, neuropsychiatric disorders after a stroke like depression, anxiety, it's high. And even the incidence of depression in caregivers is 30 to 60%. The incidence of depression in stroke survivors is 1 out of 3 or 55%. And so I guess one of the questions that I had is how do people navigate grief, Lauren?
Mm-hmm. It's a good question. And it's a tough question for a lot of reasons. One of them being, you know, grief is a individual experience and also can be a collective experience. So it's hard to say this is the way that someone navigates or experiences grief. We can say these are the ways, here are the multiple ways, but how someone individually experiences that varies. And I think that's why grief can be so frustrating for folks, is that we're oftentimes looking for answers, whether that's answer to the thing you're grieving about, or whether that's the answer to how you get through the grief. And there's often not many answers there that feel really helpful, right, for navigating that. So there's literature and research that is pretty seminal about stages of grief. And so you may have heard of Dr. Kubler-Ross, who's a psychiatrist, who came up with the 5 stages of dying. Actually, it was first focused on dying, death and dying. And then there has been a grief advocate who goes, last name is Kessler. That's right, David Kessler. And Kessler focused on how can those stages be interpreted as focusing on grief. So not just if someone is personally dying and these are these stages they go through, but if they are grieving, these might be similar stages. So anger, bargaining, depression, acceptance, denial was the first piece of that. Those are kind of these traditional 5 ways that we think about how people experience grief. Kessler even added a 6th stage recently about meaning. So after you've gone through kind of acceptance, how do you get through to meaning? Like, how do you make meaning of your experience of grief? Or how do you find meaning in life even past this grief? I would say that those are still, even in psychology or mental health counseling, are kind of some stages that we think about. The things about those stages, though, are that they are stages, but they are not intended to be linear. Meaning you could experience one or all of those pieces at similar times, or not even in that linear fashion, right? You might not start off in denial. You may start off immediately in anger, potentially, depending on the situation, right? You may start off, some people, which is, I don't know, I'm not that person, and I don't even know if I know that person, but some people may immediately go to acceptance of saying, this is just what it is. Right. And this is just a situation, and this is what I have to deal with. And you can also go back and forth, right, depending on how long maybe that experience lasts. It just varies. So
yeah, I find it to be fluid. I find
it's very fluid.
Yeah, fluidity is what comes to mind.
Absolutely. And that is tough, right, in these experiences, because we don't want fluid. We want to know, what are the stages? How do we go through them? How long will that take? And when will I be done?
When will this jello set?
Exactly. And
jello
so
just won't set.
It just won't set. That's not the thing. And so actually, I've done a little bit of looking into this, some of the specifics around their writings of this. And I thought something was really important. A quote from David Kessler, who said, "These stages were never meant to help tuck any messy emotions into a neat package. They are responses to loss that many people have, but there is not a typical response to loss. And so there's no typical loss," right? So they were saying that the intention was never for it to be linear. I think we all made it that way because we want it to make sense, and that makes the most sense to us. And that wasn't their intention. Their intention was just to try to give name maybe to emotion or experience that many people have that we hadn't been able to kind of label, to give people something. Right. So you may not say, I've gone through these 5 stages in this order, but you may be able to say, I feel like I've been in a prolonged state of just denial. Right. I feel like I've been struggling for a really long time with acceptance of this, or the depression that comes with this. Right. So it gives you some language without having to say, I'm going through step 1, 2, 3, 4, or 5.
Wow. Dr. Lauren, let me ask you a question.
Yes.
With the stages of grief, like you were speaking about, what are the? I don't want to ask like a silly question after you've given, like, it's not concrete.
No silly questions.
Yeah. Okay.
No such thing.
I'm gonna let you tell it.
I agree with that.
What can a person do to navigate those steps, though? If it's not concrete, it's fluid, but what can a person do to help navigate those steps of anger, of depression? And like Dr. Celeste was saying, when you get into the SLP office, she wound up being my mental health counselor, which was unfair to her and unfair to me. because she was very ill prepared to deal with me in that emotional state. But I didn't know, that's just where it all came out.
Yeah.
It all showed up there. It never really showed up at occupational therapy. It showed up in the SLP office.
Which would make sense to me, right? If that's a space where it might be a challenging experience, if you're having to learn new things, if you're having to explain or express something, and if speech is an area where that can be the most frustrating, kind of feels like that's where a lot of emotion might come out in the scene of where that it's all coming to a head. Right. So absolutely. I hear you saying, how do you navigate that then? If there's no concrete steps, so how do I do that? And again, I know this may not feel the best to hear. And there is still no one way or right way to navigate things, right? However, there are a couple ways you could go about it. You can just make it work for you, right? Pick and choose what some of these are that might work for you. So I made a few notes, a few things I'm thinking about. Do your own research. So things like listening to Brain Friends, right? That's a great way for someone who is a survivor.
Brain Friends.
Agreed.
To be able to
listen to the doctor, people.
But truly, right? Doing your own research of how have other people navigated this. I mean, it may be helpful to hear from your speech language pathologist, or if you have a therapist, or you may have a partner, and they may be able to tell you what they know of how to best help you per se. And it's very different also when you can hear from someone who has had a similar experience. So
like a support group.
Yeah, it could be a support group. It could be podcasts. It could be just things online. I mean, our technology is significant at this point, right? Where so much is accessible to us. So doing your own research and trying to find folks who or maybe if you can, because sometimes what we're looking for just doesn't exist yet. And maybe that's the cue that you're the one that needs to be the new voice around that, possibly.
Brain Friends.
Possibly, right?
Look at us.
So if you're doing your research, try to find maybe people or experiences that are similar to yours or you can relate to. Right. Is there a survivor that's talking about the similar thing you are also recovering from, and they have some similar identity marker, or they're also a mom, or they're also fill in the blank, right? That may make sense to you, and that may feel like that gives you some type of validation, comfort, and guidance on how to navigate that. Another thing is to lean into your care team and find new care team members if you're dissatisfied, if you are able to do that. So do you have a mental health therapist, and are they showing up and meeting your needs in the way you'd like, or your primary provider, or your neurologist if you have one, or whomever that is? Because that oftentimes can be difficult for people to navigate the recovery when they don't feel that they can navigate the experience with their provider. If you can't talk to your provider, if you feel like they are not hearing you or listening to you, if you're not in agreement with the care you're receiving, all of that can make navigating the experience really tough. But leaning into your care team, right? If you feel comfortable enough to be honest with them and be vulnerable with them about the things you're needing, so that they can actually try to best meet your needs, right? We already talked a little bit about increasing your social support. So that might be engaging in a support group if that's your thing. I think support groups are great because I think it's wonderful to be able to not only share your own story, which can help other people, but hear from other people about what helps them.
Yeah. It saved me for sure. It definitely helped me. It really, really did put me in and I am purportedly way too cool to be in a support group. I was like, I'm not going.
Most people are.
They not ready for this smoke that I'm bringing. I'm too cool. And I walked in and it was like, and these are my people. It was like a homecoming. And I wasn't ready for, that was a whole nother realization within itself. But that, but meeting those people and meeting that group was so helpful. And then, I'm not alone. And with something like aphasia, it's, half the people haven't heard of it. There's 92, it's like a high 80% of people haven't heard of it. So,
Right.
Not only do you have had a stroke, and you have something that no one's heard of.
Right.
So it's just an added layer.
Absolutely.
So I think, just to add to your point, the support groups are absolutely essential.
Mm-hmm.
Angie, you mentioned something that, I think is so powerful as far as a lot of your emotional pieces were experienced in the office with the speech language pathologist. And, I think that, of course, there's a level of frustration that could be associated with that. But I also think that there's a level of vulnerability that happens in those spaces to where you feel more comfortable with the speech language pathologist. And then that's why some of those emotions come out there. And so one of the questions that I had was, what tips do you have for practitioners or speech language pathologists working with clients that exhibit emotional distress or sadness during recovery, given that unfortunately, a lot of speech language pathologists might not have had in-depth counseling classes or helping skills classes. And so what are some simple things that they can do to support their clients?
Yeah, great question. And if you all want some of this info too later, I don't know if you all ever do any like putting this stuff in writing so people can access it later. I'd be happy to kind of give you that too, because I know I might say a lot of things. People are like, "Wait, what's all of that? I need to write all that down."
Say them slow.
I'll say them slow.
And
yes.
we'll take them notes. We'll take
You'll
them
take
show
notes. Okay.
We'll take them show notes.
Okay. But it's a great question. And just also in honesty, I always say, being honest, I'm never not honest, but just in being transparent, maybe I should say, is that most of your providers, medical providers, regardless of their degree, likely have very little training in how to truly, what we call those basic counseling skills, how to just have basic empathy, validation, those pieces. And that is surprising. That was surprising even to me. I think I was saying earlier in the show, part of I didn't even talk about all the work I do, but I also work with medical students and do some teaching and training in mental health kind of concepts. And this comes up a lot. So my first recommendation is exactly what you all already said, part of it, which is to not panic. I mean, most times immediately you hear someone say they feel something like sadness or some type of lower emotion, or maybe they're expressing emotion, maybe crying, maybe they're angry, or they're getting really kind of flustered, and immediately the provider panics. When that's truly not necessary, right? Because the panic though comes in and saying, oh my gosh, I'm not prepared. I don't know what to do.
Mm-hmm.
You don't have to know what to do. They don't need you to fix them. They need you to hear them, right?
Wow.
So if you're knowing that panic is not where you need to go, you immediately should go into leaning in, not out.
Wow.
So that might be being curious. It might just be listening. Mm-hmm. You don't have to immediately have an answer or response. You need to listen, right? You should also validate the emotion that they're bringing up and the expression of emotion. So I might say, I see that you're really upset because you're crying. I'm validating the expression itself. And I might validate and say, and that tells me this feels really hard for you, or this has been really devastating for you, if they used a word like that or something. So calling out what you see instead of immediately, I think Dr. Celeste said this, going to, okay, can you say these 3 words? So not deflecting.
Ladies, stop with the words. There's some stuff going on.
Not deflecting and not leaning out. Lean in, right? Because as you lean in, they will lean in. And some of that might start to settle a bit. And then we can have more maybe of a kind of a conversation. Some of that emotion has settled a little bit. And also reflecting back that emotion. So don't just, even if you listen, you don't just immediately go to the next topic when they're done. You need to say, this is what I heard you say. Is that right? This is what I saw. I heard you say you're thinking about this. Did I get that right? Because that also expresses to that person that you are actually listening to them and you heard what they said. And that is super important, not just because you'll then have an answer, but it's important because it lets that person know that you are with them. And that's
Right.
really the foundation of what that person might be needing in that moment. Having some cultural humility is important because thinking about people express sadness, frustration differently. And so someone might be pretty stoic or flat, as we might say. They might not have a large expression of emotion, which we may just naturally interpret as, oh, they don't care.
Mm-hmm.
But their words may be saying, but I feel this.
Right. But I feel like I'm drowning.
Mm-hmm.
Right.
So just because their affect is not exactly matching with their words, that's a place for you to be able to be curious and say, I hear you saying this and I'm seeing you look like this. Tell me more about that. Right. Lastly, I'd say if it, I'm not that you need to, that's not going to take you too deep, I feel like, into counseling, because I think that worries people of that. What if we start even getting far? Maybe if they're having suicidal ideation, right?
Honey, because they be quick to be like, that's out of my scope of practice.
Yes. That's out of my scope.
Girl, you just
right?
asking them how they feel.
You're just asking them how they feel. To be fair, that person may continue, and that may come up where they say, well, I have thought about harming myself. I have thought about, what it would be like if I wasn't here. Again, that's okay for you to say, I'm not an expert in that area, and it is so normal to have that feeling and to have that thought. So that's not you treating the issue, that's you normalizing that experience, and that's validating what they're sharing for you so that they will be comfortable. They might share more, right? And they just know that you're with them. Lastly, then you need to check in and see, how do you get them to the right person? So do they have a mental health therapist? If not, how can you help support getting them there? And if they do have one, encouraging them and say, I so appreciate that you shared this with me. This will be great to share with your therapist if you haven't already. I think they could be helpful. And then you can always revisit this. People get worried. Practitioners especially can get worried that if you are talking to someone about a negative experience they're having, or even if it's like a thought of harm, that you're going to make them feel worse or that you're going to make them harm themselves, when research says that's not true. If someone's already thinking about it, you can't make them go any further than that. They've already maybe have a decision. What you can do, though, is not ignore it. Because if you ignore it, that might be the thing that triggers them, versus if you acknowledge it, that lets that person know, oh, someone else is noticing that I'm having trouble. This is something maybe I should talk about. I should do something about. So those are just my big ticket items that I say.
They are big tickets. I am here. No, that is so important to what you're saying, and I can definitely relate to that. So I guess now I want to know, what would you consider to be the biggest myth about your field? After you've just laid all that on me. So what would you like to tell people that is not true about the field of mental health?
Mm-hmm. This is such a funny question to me. And, I was reflecting on what might be biggest myths. I thought about the things that I have heard people say to me that I've identified as myths. So I will definitely talk about that.
Okay.
But there's tons of them online if people are interested. The top 3 for me, the first one is that psychologists or mental health clinicians are psychics and that they can read your mind.
What?
You'd be surprised the amount of people who have I don't even always lead with saying that I'm a psychologist, because then I get all of these myths later and people say, "Oh my gosh, you're reading my mind," or "What am I thinking right now?" And I'm like, that's not the same thing. Not, no shade. And I think psychics are very well possible. I can see that. And that's not me. Psychologist. Right. I studied the brain and studied behavior. Not the same thing as reading your mind, but I get it, right? Because people think like, "Oh my gosh, how did you know that?" And it's like, well, I study behavior, and you've been doing the same thing for 20 years.
Well, you've been coming in crying for the last 2 weeks. So the fact that I figured you might cry today and you might want to talk about your mother again, yeah, patterns. It's not algebra. There's a point where it's not algebra. I'm not psychic. It's just not that hard.
I'm trained to understand pattern, right?
Right.
So that's one I always think is funny. The second one is that people might think that we are constantly analyzing them, that we're constantly picking apart what you're doing and what you're thinking, and we're trying to understand everything about you. And it's like, no, the truth might be is that it is true. My brain does constantly work in a mode, I would say, of analysis. That's just true. I think I'm consistently surveying my environment. I'm consistently questioning why is something happening this way versus that way. And I think that could be normal for most people. It's not true, though, that I'm looking at every person that I interact and think, why do they think like that? Why do they do that? Why do they choose to wear that? And why do they stay in that relationship? And they clearly have this kind of issue. And I don't do that. I tell people,
you don't have that type of time. You ain't got that type of time.
Listen, I tell folks, if you are not my client, I probably don't even care that much to analyze you, to be honest. I just don't.
Where's your Blue Cross and Shield? Where's your insurance card? Like,
I'm thinking about my own life, let alone other people.
Right.
Like, no.
You ain't put on no copay or nothing?
Not at all. Not at all. The last one is that, that talking about your problems will either solve everything or nothing at all. I think we get
what?
Talking about your problems will either solve everything or nothing at all. I think we get a lot of people who think you just need to go to therapy. If you just go to therapy, you would be better. The reality is, going to therapy is not just about talking about your problems. Going to therapy is learning a lot about yourself. It's about learning skills about how to be a better person, or how to manage maybe some of the things you're dealing with. And it's about practicing those skills in real life. So there's this misconception that if you just go to therapy, you'll learn everything you need to know, or you'll be taught everything you need to know, and you'll be this better human being, or that the issue will just completely resolve. And that's not exactly true. And on the flip side, we do get people who say, I don't need to talk to anybody about anything. That's not going to do anything at all, which is not true. That talking about it is a part of it, right? It's just not the end all be all. So those are just the top 3 that I thought about, like those I really like. And I see them come up a lot.
Wow. That's awesome. That's crazy. That is crazy.
Aren't those funny?
This has been so good. And we're almost at time. And so, Angie, I wanted to see if you had any other questions for Dr. Lauren
is this rapid
that
fire?
You think are... You said what?
Is this rapid fire? Is this fast money?
No. And she'll drop it on me, and she's like, "Listen, I know you have aphasia and that brain damage, but Angie, what do you think?" And I'm like, come on, man.
No time to prepare. Just
right. Go. But no, I think I do want to know, first of all, are you accepting clients? Is that something that you would be interested in if somebody that a listener or two or whatever wanted to reach out and find, especially Black mental health people are hard to find. You guys are the unicorns in the room. And fun fact, that's how I met Dr. Celeste. I was calling her, asking her.
So true. Yeah.
Oh, she didn't say nothing about you, sis. She didn't even say nothing. She didn't even say nothing. Used to be my homie, now you act like you don't know me.
Oh
Where's
my
she at?
goodness. I don't think that's it. I don't think that was it. It's tough. You're so right. You're so right. It's tough. I am not, and it's difficult, but just because my line of work is a little different, because I don't work for myself. So I'm
Mm-hmm.
not just consistently open or available to take new folks. I work for an organization. I don't want to call it gatekeeping. It's not gatekeeping, but it's really protective of how you can find the therapist and interact with them. So it's like you have to be a patient of our system and certain
Sure, I
clinics
understand.
to be
I
able to
get
see
that.
me.
I get that.
So no, I'm not. However, I am always open to talking with people about how to help them find someone. We're also licensed by state. You might find some therapists who are licensed in multiple states. So for example, you may be in Georgia, but they're licensed in Jersey and Georgia, and so they can see you. I'm only licensed
Absolutely.
in the state of Oregon, so that also limits me in a certain way to people who live here. But I'm always open to talking with people and helping them find someone for themselves, because I know it's
That
hard.
is awesome. I do believe that when they give you a speech pathologist and occupational and PT, I think they need to give you, especially
Oh my goodness, yes.
after a stroke. You've had a brain attack. Like, why would you not get somebody to? You might want to chat that up. You might want to chat that up.
Yeah,
Absolutely.
and it's so interesting that you say that, because that was one of the, Dr. Lauren was someone who I went to right before I finished I actually had finished my PhD coursework and I was writing my dissertation, and I knew that I couldn't graduate without really getting some more helping skills. And so, I went to her and said, "Hey, I need to take a counseling class. What do you think would be appropriate on my level?" And taking that helping skills class, I think, really made me a better practitioner, a better researcher. And so that's a piece of advice that I give to any practitioners out there working with individuals, especially if you're working with stroke survivors with aphasia, is to take a helping skills class so you can become more comfortable when some of these very real instances happen and you're not ignoring people's feelings, but operating in a space that you feel comfortable in.
I agree. Both of those are so true. Both things have to be true. I think if you are truly going to be an effective practitioner, you need to have both your own foundational knowledge of helping skills. So just what we said, the basics, validation. How do I validate? How do I show empathy? How do I reflect back a feeling, right? Those are basic skills to just help someone feel heard and understood, not about treating an issue. So as an effective practitioner, your training, your clinical training may not have a course in your program for that. And you might have to step outside of your training and go to, counseling or psychology and learn some of that. And at the same time, as an effective practitioner, you need to have the insight to know when you should be trying to connect your client to a trained mental health professional, right? Both things have to be true. So I agree with both of y'all.
I have one more question, and I know we got to wrap up, Dr. Celeste. Please start giving me the time look.
Oh man.
No, she will. She'll side-eye me in a heartbeat.
Tell her we're having so much fun.
What is your oh God, medication? What are your thoughts on medication?
Good question.
Great question. And I don't know if I actually said this earlier. I know I said vaguely that I work to support folks who have survived from chronic illness or disability or navigating that. I've also had a fair amount of patients who have had neurological trauma, from strokes to concussions, even like a mild concussion. I might see someone. So I totally empathize with the struggle that it can be of the mental health parts of navigating that experience. And so I just want to call that piece out, that I've seen that firsthand and how stressful that is. Medication, I am in favor of medication. I am also in favor of the survivor's choice around medication. I tend to encourage folks to consider medication for a couple reasons. Medication might be helpful with managing anxiety symptoms, depression symptoms, trouble sleeping, especially in the earlier stages of recovery, because there's so much variability to experience and so much that's still trying to level out in that beginning part of recovery, that folks can be typically dysregulated at the earlier parts, where just adjusting to the injury itself, let alone all the residual effects of that, make it very difficult for you to function, go to work, take care of things you need to, take care of yourself, your basic hygiene needs, any of that. So I think sometimes medication could be helpful to help with stabilization. It doesn't mean that you have to stay on it forever. That's a decision that you can make in conjunction with your care team. So I'm in favor of it to help with that initial stabilization to get you going. And if it's something that you and your provider feel like you want to stay on because you notice that it keeps you in a place that you feel comfortable, I'm in support of that too. I'm also in support though of choice. And then some folks feel that that's not the right fit for them. It's less helpful to push something on someone to get them just to change their mind. That's not how people change or make decisions. They make decisions and change because of what they want. And so I normally just give the information, give the education. I can answer a lot of questions around it. And if the decision for them is still no or not right now,
nope.
I respect that. And we can work together. But I've seen significant benefits from folks who have also been on medication.
No, I wouldn't take it at first, and then after about a year or like my second year in, it was like, no, I have to. It was just a realization for me that I've had a brain attack. Like I'm chemically off. Like this is not normal. I can't get myself out of the sunken place that I wound up falling into, and I couldn't sleep. And I just needed something, because when I realized is I couldn't sleep because I was afraid I was going to have a stroke in the middle of the night. So every time you got to REM sleep, I'm like, no, you don't. I'm up.
That's
you ain't
right.
catching me out here.
That's right.
But,
and we take that so personally.
We do. And I think that's that we were always just, if you pray it off, you think it off, you positively think it off, and you're going to be fine. And sometimes you might want to take that trazodone and stop playing.
Because if you took the trazodone and you slept better, you may have more mental functioning during the day to recognize I could probably be more functional than I think I can. Yeah. And it's not just me being lazy. It's not just me that I just can't get it together.
Or it's motivated. So many people say that, like, oh, the client's not motivated.
They may not be sleeping. And not poor sleep has such a negative impact on our day-to-day functioning. You are just not your best self when you don't have sleep. Your brain just can't function in the way that it needs to, on top of if you have an injury to your brain.
Right, on top of an injury. And it was, it was definitely a thing. And
there's probably
I'll do a commercial for Smith Klein or whoever makes it. I will do a commercial for them people. Okay? Because listen, I was so like, absolutely not. Nope. I'm going to be all right. Yeah. Okay. Yeah. I'll take that. That'll be fine.
May I ask? I know we're out of time. I'm a therapist. I know, right? I should stick better to time. I promise. But just my question. Yes. I'm curious. Could you share why that was for you? Your hesitancy and for so long?
Because I'm Black. I'm gonna give you a short answer. Because I'm Black, and that's how we certain things we just don't do. We don't do medication. We don't. The same reason the person may not want to go to therapy. Because I'm going to figure out another way, be that prayer or brandy. I'm going to figure out a way to get over this without going that route, because that ain't our route. That's their route. That's what they do. I don't need that. And, there's the fear of, well, what does that mean? And for me, I didn't want to get on it at first because I felt like if I get on it immediately, I won't know what's wrong. I can't, you know what I'm saying? Like, I can't see where my deficits are. And even if it's helped me, if I get on it immediately. So for me to take that time and give myself, okay, all right, no, I do need some help. Let me go ahead and make this call, get with old doc, and like, yeah, I can't. This is harder. This is more difficult for me to handle, and I could use some assistance. And it is, I only take half of what they prescribe. Throwing that out there as a quick sidebar, but it has really helped.
Your own medication.
See, but then I think that I think that then is right. But I think that then that's another conversation that has to be had is the point of, once you accepted it, there's still a space to where you're managing it in what you feel comfortable, where, I would think what then is the hesitation in sharing with the physician, I really only need this prescribed this way. And giving that feedback so then they can better manage you as well. You get what I'm saying? Like, if you're surviving off half of it, then why isn't the prescription just half of it? And actually, would that knowledge be better for the practitioner or the physician who prescribed it to say, hey, I know you said it's 10 milligrams, but I'm really good with 5. And being your own advocate in that way.
Well, actually, just to clear it up, she actually told me what she was giving me, we'll say 10. And she was like, she said, well, take 5 first.
Okay.
And see how you do on that. But I've never gone to the whole hunch. I've never went to the whole hunch. Because less is more.
Yeah.
Less is more.
And my follow-up question, Angie, is did you do your own research once you made the decision to go ahead and start with the medication? Did you do your own research that made you feel more comfortable, or was it just like, all right, I'll try it?
It was really, all right, I'll try it. It really was. I mean, I did some research. One of my best friends is a pharmacist. Shout out to Chip. And so I asked my friend what would be best. And he was like, yeah. And and then I do some little bit of research, but I really leaned on him because he's in that field, so that really helped me out. So again, shout out to Chip.
I think that's a whole different topic, right, for a different day. But I just wanted to call out, because your question to me was, what do I think about medication, right? And I'm in the field, so that doesn't guarantee I'm going to be an advocate, but more likely I'm probably going to be an advocate than the average person because I work in the field and I've seen how it works. And things for people to consider that impact a lot of these decisions: stigma, there's cultural influences, there's also history, and all of the history of Black folks' experiences in medicine and how we've been treated in medicine, mistreated consistently in medicine. I mean, there's tons of layers to more than just you saying, I just don't want to do it because that's just not what I do, or that's just not what we do. There's many more pieces to it. So I really just encourage people to have that conversation with someone they trust, whether it's a medical profession or not. It's important to talk through it, though, just so you can make sure you're making a decision you really feel comfortable about and not just the decision you think is the right thing to do.
Absolutely.
Oh, this has been so good. I really, really appreciate Dr. Lauren coming. You are officially a brain friend. We're going to send you some merch.
I'm so excited. I want to be a brain friend. Yay.
Thank you for being our first guest. This has been so exciting, and we learned so much. And I'm sure our listeners are going to be like, wow, this was amazing.
I hope so. Thank you all for doing this. I mean, it's such a important space, and I just can't wait to see it continue to grow. Y'all have been doing so wonderful.
Thank you.
Thank you. And we'll make sure to include all of Dr. Lauren's notes as part of our show notes for this episode. Thank you all.
Peace, y'all.
Bye.